All right. Good evening. My name's Jody Lefford, if you didn't already know, and welcome to my final presentation for instructor methodology. Tonight we're going to be going over ketamine versus etomidate, a comparison of induction agents and a drug-assisted airway management with a demonstration of how to perform. Demonstration is used loosely here. It's going to be more of a walkthrough of the procedure. Trying to demonstrate how to perform the skill is difficult at best with this platform and media. So I will walk through the algorithm, the protocol for the state and for my local agency of how we do it. I will try to be as detailed as possible to explain the procedures where you can branch off and have different treatment modalities upon that path, and where you might deviate from having to do a full-blown drug-assisted airway. I will also show examples of all the adjuncts where you might use different things in the event that you're going down this algorithm. So let's just go ahead and jump right in. So we're going to start with trying to define what a drug-assisted airway is. These might be a little out of order, but we'll also go into indications for use of a drug-assisted airway. We'll talk about the mechanisms of action for ketamine versus etomidate. We'll do some comparisons, the effects of both of these medications, and then, as I said, we'll do a walkthrough of the procedure, and then we'll have a conclusions and a summary slide. So the great debate, ketamine versus etomidate. So from debate to data, emerging insights into RSI induction with ketamine versus etomidate. So there's been a big push in the industry to not call it RSI anymore. RSI stands for rapid sequence innovation or rapid sequence induction. What we've found is that as a midsummer, if you will, it's not really rapid by any means. This whole procedure can take time, upwards of 5 to 10 minutes, to really get the patient induced, to get the patient ready for induction. So, and it's more science and data driven too. It's more about resuscitating the patient. And what we found through data was it's not always necessary to take that patient's right for them to breathe on their own away from them. Sometimes we can prevent having to intubate a patient, and using ketamine is a lot more beneficial in our patient populations. And that's where the debate comes in, is instead of jumping straight into using etomidate and then pushing paralytics, we can use ketamine and the patient still has a respiratory drive, and then we can just assist that respiratory drive. So definition, DAA stands for drug-assisted airway. This refers to the use of pharmacological agents to facilitate intubation and maintain patient stability during airway procedures. This includes the use of sedatives, analgesics, and paralytics. Common induction agents. So induction agents are used to achieve sedation and amnesia prior to intubation. The main ones we know about that are used are ketamine, etomidate, and propofol. And we're going to be focusing on ketamine and etomidate. Propofol in the pre-hospital world is only really used for interfacility transports, and it in North Carolina has to be started at the hospital, already on a pump and infusing, and then we just kind of pick it up and continue the infusion. We don't really mess with it, tinker with it, so we're not going to worry about talking about propofol. So the MOA, mechanism of action, ketamine. Ketamine is a dissociative anesthetic that works primarily by blocking the NMDA receptors in the brain. Provides sedation, analgesia, and amnesia without significant respiratory depression. And this is why a lot of people have really fell in love with ketamine. It's come in vogue recently in the last decade because it hits all the check boxes. You get your sedation, you get your pain relief, you get that amnesia effect all in one nice little package. Whereas etomidate it's just the sedative. It doesn't have anything for pain relief. It doesn't have anything for really the amnesic effect past the initial induction. So your indications for ketamine use, trauma. Ketamine is useful in trauma patients, especially those with hypotension, as it preserves blood pressure and heart rate. The only exception to the rule with trauma is it's still questionable about head trauma and the intracranial pressure rise with trauma patients. You know, some studies you read, some trauma surgeons in the United States will say ketamine's totally fine to use with, you know, head injuries and it has no effect on ICP, and then you have other ones that are saying it's horrible for ICP, don't do it. So that data needs to be driven by your system, your medical control, and what science they're listening to. Excited delirium. Ketamine is effective in managing agitation and combativeness, especially in patients with excited delirium. This has come into the spotlight in our field very big in the last 5 years. Everyone knows about the Colorado case and what the paramedics had to endure out there with excited delirium. And, you know, in their state and in their protocols, they've actually removed that language from using it. They don't use excited delirium anymore. So it's kind of a point of contention in the country right now with ketamine and agitation and combativeness. Your asthma and COPD patients, it provides bronchodilation, making it useful in patients with obstructive pulmonary conditions. More benefits of ketamine: hemodynamic stability. Ketamine increases your sympathetic output, which is advantageous in hypotensive patients. So again, we're talking about those hypotensive patients. You get a small rise with your blood pressure when you give ketamine. So if you've got that patient that's walking that borderline, you know, between hypotensive and normalcy, ketamine's probably going to be a better choice for you. Airway protection, again, ketamine preserves the airway reflexes, making it less likely to result in apnea or respiratory depression. Analgesic properties: ketamine provides pain relief, reducing the need for additional analgesics. The great thing about ketamine, like I said, you get the pain relief, you get the sedation, and more pain medications. One of the side effects of most all of our pain medications that we carry pre-hospital, they have a hypotensive effect. So if we have someone that's in pain, 9 times out of 10 when we push fentanyl, we push morphine, we see a decrease in blood pressure. So if we're already seeing someone that's hypotensive and then we give them pain management for post-intubation management, we're now going to take them further. So if we use ketamine on the end of that, we might see that blood pressure bump up a little bit, and then we can kind of fluid bolus them a little bit or do some pressor action on the back end of it, and it's more beneficial for our patients. So let's talk about etomidate. Mechanism of action for etomidate. Etomidate is an intravenous sedative that works by enhancing the GABAergic activity, leading to central nervous system depression and hypnosis. It's a potent sedative with rapid onset and short duration of action. 30 to 60 second onset, about 100-second duration per 0.1 milligrams per kilogram. So I mean, it's very powerful, very quick to set on. I'm going to consult my notes to make sure I'm not missing anything. Okay. So etomidate is commonly used in patients who do not have hypotension, as it does not significantly affect cardiovascular stability. Okay. Yep. Patients with neurological conditions, etomidate has minimal effect on intracranial pressures, making it suitable for patients with head injuries. So again, we go back to now that science of they have a head injury, we're worried about intracranial pressures. This might be better for those patients. But then we're walking that line too of we're hypotensive, but we've got a head injury. Which way do we go? So then we fall back into which one's going to kill them first, the not breathing or the head injury. But that's a lecture for a different day. your benefits of etomidate. So cardiovascular stability. Etomidate does not cause significant changes in blood pressure or heart rate, making it ideal for patients with stable hemodynamics. Etomidate is short acting. So remember back to the previous slides where I said about 100-second duration of action. So short duration of action makes it easy to manage in the field with minimal prolonged sedation. So something happens, we change our mind, we no longer want to go through with the procedure, we can just let the etomidate wear off, we can continue resuscitative efforts, we can continue to bag the patient, deliver the oxygen, do those methods. This is going to burn off. Minimal respiratory depression. Etomidate's respiratory effects are generally mild, allowing for controlled airway management. This is on our end. Once we push the etomidate, patients can go sedated, their respiratory drive is going to depress a little bit. It's going to make it easier for us to manage them, but they're still going to have some drive of their own. So let's get into the comparison of ketamine and etomidate. So when we look at the hemodynamic considerations of ketamine versus etomidate, ketamine will increase your heart rate and your blood pressure, making it beneficial in your hypertensive patients, but it may exacerbate hypertension in others. So if you've already got someone that is excited delirium, they're very agitated, if they've taken a lot of drugs that are causing this agitation, those drugs or medications may cause a rise in blood pressure. So we have to be cognizant of giving them ketamine on top of that may exacerbate that and make it worse. However, for most patients, the side effects of that are going to be far outweighed by the benefit. Etomidate maintains, for the most part, your hemodynamic stability, which is preferred in patients who are already pretty much stable, but can be problematic in patients who are hypotensive. So again, we're pounding that point to the ground of, if you've got someone that's normotensive and you're not really worried about them deteriorating rapidly with vital signs, you're not worried about agitation, combativeness, you're not worried about them going hypotensive, then etomidate might be a good path to go down. But if we're in that other aspect of things, then ketamine is probably going to be our better choice to go to. And I'm going to try and be impartial, but once we start walking down the algorithm later in the presentation, you're going to see where I lead, and I'll probably interject a little more of my opinions and views in this. But again, I'll try and stay as impartial as I can. So respiratory effects. Ketamine generally preserves airway reflexes and respiratory drive, making it safer in patients with compromised airways. And etomidate causes no respiratory depression, but does not offer the same airway protection as ketamine. So what do we mean by this? So ketamine preserves reflexes and respiratory drive. So you push the ketamine, your patient's still going to be breathing as they were before. They're still going to be moving air, they're still going to be trying to breathe on their own. It's just going to relax them, the pain management, just all around cognitively, they're going to go down a few levels. Whereas etomidate, they're not going to have that same protection. The sedation factor of it is going to take away some of those gag reflexes, some of that protective airway that they had before. So that's where etomidate and ketamine differ. But it's funny to say that because as we go through the DAA protocol and we're looking at that, you'll see when we talk about resuscitating versus intubating and doing a DAA, ketamine is preferred for the fact that once we give the ketamine, we can actually start resuscitating someone and not have to worry about doing the full intubation because they became more manageable with the ketamine. Hopefully I can illustrate that point and make it make sense. So neuroprotection, ketamine does not significantly increase intracranial pressure and may be beneficial in trauma or neurological patients. So see, when I pulled my data for this presentation, I was pulling from multiple different sites, and here's where I was kind of conflicting with myself, because I was getting data from different med journals where some of them were saying, you know, ketamine's great, except for in hypertensive patients and patients with head injuries and head trauma. And then I was reading some journals that were like, ketamine's great all the way around, even in trauma and neurological patients. And it's like, so which way do I go? So again, whatever system you're going into, whoever your medical control doctor is, follow their guidance and what they tell you that the science is they're following. Etomidate has minimal effect on intracranial pressure, making it ideal for patients with head injuries or neurological conditions. Okay. So, clinical scenarios for use. Ketamine is preferred in patients with trauma, hypotension, or agitation. And etomidate preferred in hemodynamically stable patients, particularly those with neurological conditions or head injuries. So again, you see how my data is conflicting even in my own presentation. And I put this in here like this to show you that, you know, while we are in the medical field and we're working with science, the science can be conflicted. And you can pull data from all around the world with different scientists, and left hand's not going to talk to the right hand all the time. But at the end of the day, you got to do what's best for your patient. And for me, etomidate is when you have someone that is truly more stable, it's more airway based, airway driven, and you know you're going to go that full path of taking that airway from that patient. Whereas ketamine is more, it can be trauma based. We're more focused on resuscitation and seeing if we can just fix or correct the problem at hand, and troubleshooting before we go the full measure of taking the airway from them. So here's where we're going to get into walking down the protocol. Okay, so this is where we're going to spend probably the bulk of our time. Now, I'm not just going to sit here and try and read the protocol to you, but stick with me here. So, indications for a drug-assisted airway is failure to protect the airway, they're unable to oxygenate, unable to ventilate, or they're impending airway compromise. So think about the bad asthmatics, the bad COPDers, your unconscious unresponsives with snoring respirations, the people that are breathing 4 times a minute and you've checked pupils and they're equal and reactive and you know it's not narcotics, or you've tried Narcaning them and bagging them and that's not correcting the issue. You know it's not a cardiac etiology problem. So we know that it is an airway issue. So we look over at this pearl box here and it says, you know, protocols, airway 1, 2, 3, 5, 6 should be utilized together. Excuse me, even if the drug-assisted airway protocol is not being utilized. So our entire toolbox needs to be used is what it's basically saying. And that's every time we do any call, we should be using our entire toolbox. So pre-oxygenate 100% O2, IV-IO access. We know this. You know, tend to get 2 points of access because once we start doing these things, we take away a person's right to breathe on their own. We do have to intubate them. We're going to stimulate that vagal nerve. We might cause some relative hypotension or bradycardia by doing that. So we might have to fluid challenge them on the backside. We want as much access as we can get on these patients. So assemble your airway equipment, suction equipment, alternative airway devices. So When we talk about our alternative airway equipment, if you remember back to my first presentation was on BLS BVMing, right? It was a good recap on a BLS skill at the ALS level, because the majority of being a good ALS provider is being a really solid BLS provider. So when we go back to that BLS presentation, it was all about using a bag valve mask, right? And it was also about positioning the patient. It was about head tilt chin lift. It was about jaw thrusting. It was about a good EC clamp on our patient. It was about using the proper adjuncts, MPAs, OPAs, high flow cannulas, non-rebreathers. So when we talk about assembling airway equipment, one of the first things we should be grabbing our high flow cannulas. If we don't have high flow cannulas, then we should be grabbing just nasal cannulas and non-rebreather mask. Put 2 sources of oxygen on those patients. We're trying to wash out all that built up nitrogen that they've got in their body. Even if they're not moving air, the residual push of oxygen into the lungs is going to cause a nitrogen washout. So we want to do that. So 2 NPAs, 1 in each nair, an OPA in the mouth, EC clamp. Hopefully you've got a partner with you. One of you double EC clamp, have a fireman or a rescue responder bag for you. Your partner should be assembling the rest of your gear if you're not. What other gear do we need? Well, rescue devices. A King airway, a Biad, or an iGel. Okay, line insertion airway devices. The gold standard, endotracheal tube with a stylet. Your handle with a Miller or a Mac blade, whichever one you prefer, or both. Because you never know, you may go in the airway with a Miller and then figure out this isn't working, but a Mac blade would work better. And honestly, everyone should have the capability of using video. I would say start your first intubation attempt with a video, because this is going to give you the best chance of seeing the airway and getting the cords on the first pass. So have everything lined up and ready. In addition to these tools, you also need to have a surgical crack kit laid out and ready on your action area. Because Fair Elway is a absolute possibility. And if the airway fails, and if there's some kind of trauma in the airway and you're not able to stick a Biad in the airway, the patient becomes very difficult to bag. We may have to go that surgical airway route. None of us want to do it, but you've got to have all your options ready. Now, in the event your patient is conscious, is alert, is still actively trying to breathe, and they're not fully deteriorated yet, this is a CPAP. And this is what it looks like out of the package. Maybe we try CPAPing them before we go to this level. But I digress. We get all of our tools out. And for those that are just absolutely crazy about them, we have the bougie. And this assists in intubation with a standard handle Mac Miller blade and then an ET tube. You can use this with a King Vision as well. I've never had great success using bougies. Some people swear by them, but it's actually a good tool to have. So have that out and ready as well. So once we get all of our airway equipment out, we've got our suction equipment out, our patients being ventilated, they're being oxygenated, we've got alternative airways like we just went over, those are all sitting out. And now's when we're going to go into the nuts and bolts of things, okay? Is our patient hypoxic? What is hypoxic? Are they satting at less than 90? Okay, that's kind of the gold standard here. Are they less than 90? Are they less than 92? Are they hypotensive? Are they dangerously combative? It's at this point we've got to make a determination. What's hypotensive? What's hypoxic? Can we not get that sat up with oxygenation, with bagging? Are they dangerously combative because they're anoxic? Or are they dangerously combative because they are just combative? Are they hypotensive? Is their blood pressure less than 90? If the answer to any of these questions is yes, then we need to jump over, we need to come down this side of the tree. And this is my favorite side of the tree, because this is where we talk about resuscitation versus straight innovation and taking someone's airway. So with this one, you see here we go straight to ketamine. Your etomidate and your paralytics are not even an option on this side of the tree. So we go straight to ketamine, 2 milligrams per kilogram per IV. So let's do some of that wonderful medic math, and it's a perfect roll in a patient's 100 kilos. So for a 100 kilogram patient, and I'm just going off of concentration strengths of medications that we have at my agency, our ketamine comes in a 500 milligram vial, and that's in 10 cc's. So that's 50 milligrams per 1 cc. So that's 2 milligrams per kilogram. So that would be 200 milligram dosage. So that patient's going to get 4 mLs of ketamine IV. Now, if we can't get an IV, or they're sitting there and they're fighting because they're combative, then we just go 4 mg per kg IM to a max of 400, which for a 100 kilogram patient, that just so happens to be their dose, 400 milligrams, which would be 8 mLs out of that bottle. We give them the ketamine, we continue to work the issue, we continue to oxygenate, ventilate, we're keeping a good proper EC clamp. Here's the thing too, let's jump back. We're bagging the patient. Do we have to take the nasal cannula off the patient? No. That nasal cannula can stay on with the NPAs while we're bagging the patient. We're now delivering maximum effort through the nasal cannula, through the BVM. We've got the nares open, giving full oxygenation. So, best thing we can do. If we're correcting the hypoxia and we're able to start getting some fluids, and the ketamine is starting to work, and we're seeing that hypoxia and the hypotension correcting, we're resuscitating the patient. We're correcting the problems. So then we come down here, patient still requires innovation. Well, no. We've started correcting the issues. Boom. Exit to the appropriate protocol. This is why I am a big proponent of the ketamine side of the tree. I'm a big proponent of the ketamine on this side of the tree, because you can still do this work on this side of the tree as well. We give the ketamine, we continue to resuscitate the patient. So before we have to worry about paralytics, we've given a sedative, we're continuing to resuscitate the patient. And if we see improvement here, like we did in this theoretical scenario, we don't have to continue here. We can be like, we're fixing the problem. We can contact med control, we can exit, we can continue on. But moving on, say we are not hypoxic, or say we're satting at 92% with all the airway adjuncts that we've got going. Say that we're not hypotensive, we're normotensive at 96 over 40. Say that we're not combative, we're very lethargic and obtunded and just lying there. So we can do etomidate at 0.3 milligrams per kilogram, which would be, our etomidate comes in 40 milligrams and 20 mLs. So that's 2 mg per cc. That would be 15 mLs. Or we could do the ketamine, which is the same dose, 4 mLs. We wait for that to kick in. We're still resuscitating the whole time. We're bagging our patient. We're not over bagging. We're bagging at the proper intervals. We're monitoring our waveform capnography. We're looking at end tidal. We're looking at the SpO2. We're watching our cardiac monitor. At this point, we think about paralytics. Which paralytic do we want to give? Now, this is a class all in itself, and we could go into Sux versus rocuronium. From a personal standpoint, I'm going to go with rocuronium. Why, you may ask? At the dose that we give rock, the onset time is very similar to succinylcholine. The duration of action is longer. Duration of action of rocuronium is around 30 minutes. The duration of action for Sux is around 6 minutes. So if I can dose them with rock, it sets on, and then it's going to last for 30. It's one less thing I have to worry about in my post-intubation management right off the bat. Because as much as we want to say this is going to happen quickly, and we're going to flow through things, by the time we get to the bottom of this, and we start going into our post-intubation management, it's going to be time to redose our paralytics. So if we can help ourselves out, relatively, as far as contraindications, there's very few, if any, contraindications to rocuronium outside of true allergic reactions to it. Whereas succinylcholine has a plethora of contraindications for it. Anyways, follow your municipality's protocols on which paralytic you need to go with. So you can go with 2 mg per kg for Sux, which just happens to match and marry up with your ketamine dosages. So it's an easy 2 mg per kg. I know that dose has 200 milligrams I need to give, but you gotta think about your concentrations. So our Sux, we would give 10 mLs because ours comes 210. For our rock, it's half, it's 1 milligram per kilogram. So our rock, we would give 10 mLs because ours comes 110. Once we give our paralytic, we wait and see that the patient's respiratory drive has ceased, they're no longer breathing. We try to intubate the trachea, okay? Whichever method you decide to choose. If you decide to go with the gold standard, direct laryngoscopy, you go past the teeth with the laryngoscope blade, past the tube. That's now an attempt. As soon as your blade has passed the teeth, you have made an attempt. And if you don't see anything, you can't get good visualization, that is a failed attempt. So, things to think about. That's why I say use the video, because the video is going to give you your best shot at first pass success. And so if we go to the pearls, this one is more towards our system. I don't know about statewide what the thoughts is on DAA with patients less than 12, but in our system, you have to physically talk to our med control doctor on the phone. So we drop down here. Let's see, where was it? There was a good pearl here. Ketamine may be used with or without paralytic agent in conjunction with OPAs, NPAs, BIADs, or endotracheal tubes. BIADs are preferred over endotracheal tubes until hypoxia and or hypotension are corrected. So again, like I said, you go down that right side of the tree, it's all about resuscitation over taking someone's right away from them to breathe. The last thing we should be hoping to do is to take someone's ability to breathe away from them, because that is a life-altering event for them and for us if it goes wrong. So with that being said, and like I had said about first pass success and failures, go into the failed airway. So definition of a failed airway is unable to ventilate or oxygenate your patient to greater than 90% during or after one or more unsuccessful intubation attempts, and or the anatomy is inconsistent with continued attempts, or 3 unsuccessful attempts by the most experienced paramedic. Each attempt should include a change in approach or equipment, but no more than 3 attempts total. So, failed airway. As soon as you get a failed airway, you should be calling for help. First thing we do, we drop back to our BLS standard of a BVM. So again, why was it so crucial at the ALS level? I felt it was a need to teach 15 minutes on proper BVM techniques. BLS before ALS, always. If your advanced airway techniques fail, you have to drop back to what is going to work. Drop back to a BVM. The MPAs should be in place already. The MPAs and the NAIRs are not going to affect your intubation techniques. That nasal cannula inside the MPAs are not going to affect your intubation. That's already going to be there, and it's already going to be oxygenating your patient. So if we're below 90 with that oxygen flowing and those MPAs in place, we've got an issue and we know it. We drop to this, we put in OPA back in. We start bagging our patient. Oxygen saturation greater than 92, yes. We just keep bagging. Don't mess with it. If it's not broke, don't fix it, just keep bagging, right? If this isn't working, we're truly in that failed airway. Okay, something has went totally wrong. We've caused trauma in the trachea. Something is swollen, just things that went from bad to worse on us. This is why we have all of our adjuncts out, right? So attempt a blind insertion airway. So our King, our LMA, our iGels, our air tracks, airway, video laryngoscopy, should have already been using that. Airway cricothyrotomy surgical procedure. That's why I said have your surgical cric kit laying out and ready to go. Because if we get to the point that our BVM is not working and it's not doing the job, then we're probably going to have to go this route. And we hope we don't ever have to go this route, but if we've failed our intubations, we went back to our BVM, and we're not seeing improvement, this is most likely where we're going to end up at. Supplemental oxygen BVM with airway adjuncts, maintain your oxygen greater than 92. So that's our failed airway. No one wants to have a failed airway, but even the best of us will experience a failed airway at least once in our career. The purposes of this protocol: an effective airway is when the patient is receiving appropriate oxygenation and ventilation. So again, pulse ox greater than 90%, and is acceptable to continue with basic airway measures. So in general, ventilation rates with BVM should be 10 to 12 a minute, like we covered in my basic presentation. So get comfortable with your BVMing skills. We should all know about Roman, Leon, RODS, SMART, all the acronyms for airway difficulties. So your RODS is for your biads, of course. Leon is for your laryngoscopy. You got to look, evaluate, obese, and then neck mobility. So let's get off of failed airways, and let's say that we had a successful intubation, and we've got our patient intubated, they're oxygenating great, our end tidal looks good, our SpO2 is improved. So, or even if we had a failed airway and we had to stick in a biad, but we've come down and we're maintaining around 92 or better on our SpO2. We're going to ventilate that patient as appropriate per age, and then we're going to do a 12 lead if it's indicated. We're going to start transporting. If your agency uses ventilators, here's where you can put them on a ventilator and adjust your ventilator as per your training protocols. If you notice that they're awake or moving after intubation, evidence of anxiety or agitation, which if you've intubated someone and done this procedure and you've got a tube down their trachea or a biad in the pharynx, they're probably going to know it's there. So we need to think about pain management, more sedation, as well as long-term paralytics. So ketamine at a repeat dose of 2 milligrams per kilogram every 15 minutes as needed. And that's just to keep them sedated. It helps with pain management. We can also do the Versed, 2.5 to 5 milligrams every 3 to 5 minutes to maintain sedation. The great thing with the agency that I work for, we have pumps on the trucks, and we can also do infusions. So with extended transport times to the trauma centers, instead of having to every 5 minutes dose them with Versed, or every 15 minutes try and draw up some more ketamine to try and keep the person sedated. Think about that 100 kilogram patient, that's 200 milligrams of ketamine. That's 3 doses from our truck and we're now out. So the easiest thing for us is to do the initial sedation, intubation, drop down, and do an infusion. And we can set an infusion up on our pumps and do a 1 milligram per kilogram IV infusion on the pump. And it's kind of a set it, forget it type thing. And then it will just run in and it keeps them under constant sedation. If we don't want to use the ketamine, you can drop down and do a Versed infusion. You run that at 1 to 2 milligrams per hour. And it's the same way as the ketamine, it will just keep them nice and sedated. And then we worry about our pain management, right? Because you gotta think, just because you're sedated, just because you're paralyzed, doesn't mean you don't feel pain. And even though you've got ketamine going, it's probably not enough to manage the pain. So we have to think about some ketamine or some morphine to help with the rest of the pain. Now, we do have to worry about our vital signs. We have to worry about our blood pressure dropping out on these. So monitoring your vital signs every 5 minutes is very important with these patients. There's a maximum of 300 mics for the fentanyl and a maximum of 10 on the morphine. And then long-term paralytics, rocuronium 1 mg per kg. Again, like I said, if you start your DAA procedure with rock, by the time you get to here, you're still in your rock window. You've got more time before you're going to need to worry about long-term paralytics again. So sedation, pain management, priority and post-airway management. Propofol we don't worry about. So final tips and takeaways. DAA is the use of pharmacological agents to facilitate intubation. Common agents used in pre-hospital for induction are ketamine and etomidate. Each has their benefits and should be used at different times. Know when to use which one. Follow the DAA protocol. And DAA protocols can vary by district, municipality, by agency. And always have rescue devices ready in the event you are unable to intubate. So again, I'm going to go back. Don't forget your BVM. But thank you. This has been my presentation. Here's my information if you feel you need to get a hold of me. I hope this wasn't too painful or terrible.